Namaste everyone. I am Iwa Bhattarai, third year medical student from Gandaki Medical College. I would like to extend a warm welcome to our guest speaker and all the participants joining our Zoom session. The Grey Medicos is a virtual platform created by medical students from different medical colleges of Nepal. As grey is the color that symbolizes the transition between black and white, and we believe that we students are in the transition phase from knowing nothing to knowing something. So we have chosen the name the Grey Medicos. We hereby bring you a weekly session where we conduct an interactive teacher-student discussion to fill up our knowledge gap with common clinical cases of our hospital. In today's session, we are going to learn about topic abortion. We have our mentor, Honorable Dr. Anjana Dangol ma'am, and presenter for today's session, Ms. Iwa Bhattarai from Kathmandu University School of Medical Sciences, Dhulikhel. We are grateful for your presence and we extend our warm welcome to you both. Without further delay, I would like to hand over this platform to Iwa Didi. Platform is yours, Didi.
Hello and good afternoon, everyone. I'm Iwa Bhattarai. I'm currently studying at Kathmandu University School of Medical Sciences. First of all, I would like to express my gratitude to the Grey Medicos team for creating such an innovative and informative platform for the medicos all over the world, which will definitely guide medicos academically and clinically. Personally, I'm really excited for the session and I believe it would be a great learning experience for all of us. Today we are having case discussion briefly, which is going to be mentored by our very beloved and respected Dr. Anjana Dangol ma'am. Ma'am, would you like to introduce yourself?
Good afternoon, Sabaijanalai. So I'm Dr. Anjana Dangol. I'm gynecologist. I'm associate professor and clinical coordinator in Kathmandu University School of Medical Science. So I have now almost experience of 17 years. So I'm involved with the medical from the first batch of KUSMS student. So I'm very proud to be here with you all. And I'm very much liking the way you have started this program with almost all medical colleges. I will not only say affiliated medical college. So I came to know just now that it is not only limited to our affiliated Kathmandu University affiliated medical college, but it is also with the other medical college. So I'm excited, like Eva. So I'm very happy that you have initiated this. Thank you. Looking forward to further discussion and class. Okay. Yeah.
So without further ado, I would like to begin with my presentation. Is my screen visible?
Yes, Didi.
Okay, let me begin. Good afternoon, everyone. Today I am presenting a case of Miss Puspa Sahi, a 23-year-old lady from Dhulikhel. She is Hindu by religion and is a housewife and is educated till grade 8. She is married to Mr. Basanta Sahi, a 26-year-old gentleman who is driver by occupation, and she is married for 3 years. She was presented to the emergency department of Dhulikhel Hospital on July 1, 2021, which is 2 days back, and was examined on the same day with chief complaint of cessation of menstruation for 10 weeks, lower abdominal pain for 4 hours, and bleeding and pervaginal bleeding for 20 minutes. Her last menstrual period was on April 12, 2021, and as per Nagel's formula, her expected date of delivery is calculated to be January 19, 2022. So history of present illness. The patient was apparently well 10 weeks back when she had cessation of menstruation, which was confirmed as pregnancy by urine pregnancy test at home. The patient was in her usual state of health 8 hours back when she developed lower abdominal pain, which was gradual on onset, initially dull in nature, intermittent type, radiating towards back, which was relieved to certain extent on rest and use of hot water. The pain later progressed to severe colicky type, not relieved by rest and warm compression, and it was severe enough to hamper her daily activities. She also developed bleeding per vaginum since last 20 minutes, which was bright colored, non-false smelling, progressively increasing in amount, for which she used 3 fully soaked pads. She gave no history of patches of fleshy mass or grape-like vesicles. There is no history of trauma, fever, excessive nausea and vomiting, burning micturition, bleeding from gums, petechi, use of intrauterine contraceptive devices, epigastric pain, blurring vision, awareness of on heartbeat, no difficulty in breathing, yellowish discoloration of skin, belching, bloating, diarrhea, and constipation. So these are all negative history for the present illness. For the above symptoms, she presented to the emergency department of Dhulikhel Hospital at around 9 a.m., where normal saline and IV medications were given. Some blood investigations were done, and USG was done via portable USG machine. History of present pregnancy. This is her first pregnancy, which was unplanned with no pre-pregnancy counseling. The pregnancy was diagnosed by herself at home by urine pregnancy test, 2 weeks overdue her cycle. So, history of present pregnancy. There is history of first trimester, history of cessation of menstruation with mild nausea and vomiting, and increased frequency of micturition and breast tenderness. She did not go for ANC visit, and folic acid tablets was not taken. She gave history of per vaginal spotting in her 8th week of gestation, which is 2 weeks and 5 days prior, for which she was hospitalized for 2 days when she underwent complete when 2 days when she underwent complete bed rest, wherein blood and urine investigations and USG were done, which were found to be normal. Tablet folic acid was started and was prescribed with one oral medication, the name of which could not be recalled by the patient, which is most likely to be progesterone tablets. On discharge, she was properly counseled, advised bed rest for 2 weeks, and asked for regular follow-up. Weight gain was not documented. There was no history of burning micturition, fever, excessive vomiting, or pain abdomen. There is no history of consumption of alcohol, unprescribed drugs, smoking, or exposure to radiation. So furthermore, in menstrual history, she attained her menarche at the age of 14. Her cycle is regular, occurring every 30 days, with bleeding period of 5 days. She uses 2 fully soaked pads per day. There is no patches of clots, no dysmenorrhea. There is no postcoital bleeding and no intermenstrual bleeding. Her last menstrual period was on April 12, 2021, and her expected date of delivery is calculated to be January 19, 2022, and she is in her 10th week of gestation, more precisely 10 weeks and 5 days. Obstetric history. This is her first pregnancy. Furthermore, in contraceptive history, she gives no history of use of any method of contraception. However, her husband used condom during coitus. Past medical history, there is no history of chronic illness like tuberculosis, hypertension, diabetes mellitus, thyroid disorder, asthma, chronic heart disease, and chronic renal disease. There is no history of prior surgery, blood transfusion, or previous hospitalization. Family history. There are 4 members in the family. There is no history of twin pregnancy or cancer in her mother or sisters. There is no history of chronic illness like hypertension, diabetes mellitus, asthma, and TB in the family. Moving on to the personal history. She is a non-vegetarian and consumes mixed diet. She is non-alcoholic and non-smoker. Her appetite is normal and sleep pattern is normal, and her bowel and bladder habit is also normal. Socioeconomic history. They live in a Bucky house with 6 rooms and separate kitchen. They cook food in LPG gas and drink tap water without any method of purification. Wastes are disposed by burning. Separate latrine facilities are available. They rear cattle, 1 buffalo and 2 goats, and the cattle sheds are separated from the house. She is housewife and has studied till grade 8, and her husband is a driver and has studied till grade 8. Drug and allergy history. No known allergy to drug, dust, pollen grains, or any food particles, and there is no history of drug abuse. Ma'am, shall I proceed?
Yeah. So do you like to tell the history or summary of the history, or you like to conclude it at once?
Ma'am, I would like to tell about general examination and then tell about the summary.
Sorry?
Ma'am, I would like to tell the summary at the end after the
Okay,
first
then you
part.
can continue. You can continue. Continue, please.
On general examination, the patient is ill looking, alert, moderately built, conscious, cooperative, and well oriented to time, place, and person, lying supine on bed with green cannula on dorsum of her left hand. Her BMI was calculated to be 21 kg per meter square. There is no pallor, no icterus, clubbing, and no sinuses, and her hydration status is intact, and peripheral lymph nodes are not palpable. On examining the pulse was recorded to be 90 beats per minute in right radial artery, which was regular in rhythm, euvolumic. There was no radioradial and no radiofemoral delay. The condition of the arterial wall is normal, and all the peripheral pulses are palpable. On measuring the blood pressure was recorded to be 110 by 70 millimeter of mercury, measured in right brachial artery in supine position. The respiratory rate was 21 breaths per minute, thoraco-abdominal type, and there was no use of accessory muscles of respiration. And the temperature was 98.2 degree Fahrenheit taken in left leg axilla, which equivalents to 37.6 degree Celsius. On systemic examination, the respiratory examination, there was normal vesicular breath sounds, which was bilateral normal vesicular breath sounds, equal air entry, and there was no added sounds. On cardiovascular system examination, the first heart sound was heard, which was normal. The second heart sound was also normal, and there was no murmur. And on central nervous system examination, it was grossly intact. uh, Abdominal examination. On inspection, the abdomen is slightly distended below the umbilicus. All quadrants move equally with respiration. The umbilicus is central and everted. Linea nigra is present. There are no scar sinuses or dilated veins, and the hernial orifices are intact. On palpation, on superficial palpation, there was tenderness over the lower abdomen, right lower and left lower quadrant. There was no local rise of temperature. The fundal height was just above the pubic symphysis, which corresponds to the gestational age. On deep palpation, there was no organomegaly or irregular mass. On percussion, the tympanic node was heard all over the abdomen. Auscultation, normal bowel sounds was heard, 3 per minute, and there was no brood heard or any added sounds. On speculum examination, there was profuse bleeding from the internal os with passage of clots, and the internal os is dilated. On digital examination, the size of the uterus corresponds to the period of gestation, and the product of conception was felt through the dilated os. Uterus is soft and enlarged, and there is no cervical motion tenderness. So summary of my history is 23 years old primigravida lady at 10 plus 5 weeks of gestation with excessive fresh vaginal bleeding with progressively increasing lower abdominal pain, severe colicky type, along with history of threatened abortion 2 weeks back. There was no passage of fleshy mass and grape-like vesicles. On general examination, she was ill-looking and respiratory rate was slightly increased. On abdominal examination, the size of the uterus corresponds to the period of gestation and lower abdominal tenderness was present. For speculum examination revealed profuse fresh bleeding and clots with open internal os. On digital examination, the uterus was soft and enlarged and product of conception felt through the open os. So based on the following summaries and positive points, my provisional diagnosis is inevitable abortion.
Okay, Iwa, thank you very much for your case presentation. Am I audible?
Yes, ma'am.
मेरो कम्प्युटरमा चाहिँ कहिले कहिले फ्यान के हुने बेलामा चाहिँ अलिकति आवाज आउँदो रहेछ बट इट इज नट कन्टिन्युअस त्यही गरी डिस्टर्ब भयो भने प्लिज लेट मी नो है ओके सो she has very nicely presented history. So actually the discussion today will be for the bleeding in first half of the pregnancy. So very normal complaint that one can have in the bleeding in the first half of pregnancy. So we have to remember almost all the differential diagnosis. So I would like to start my presentation, but before I start with my presentation, if anyone of you have any question up to here, so please keep it in the text box or you can ask directly. Iva, would you close your presentation, so give me an access for the presentation.
Sure, ma'am.
So it's nice. Almost 120 students are there. Yeah, from different medical colleges. So I have seen that it is not only from the final year, but from the very third year students are also there. It's nice. Yeah. So I'm sharing my screen. So today we will be so she has very nicely elaborated her chief complaints. So when we before we jump directly to the in the class, so because this is case presentation, so I'd like to go accordingly. So Eva mentioned that her patient, so she was amenorrheic, so she was having symptoms of amenorrhea, okay, and then she developed pain abdomen, and she developed pain abdomen, and then she developed vaginal bleeding. So in chief complaint, so amenorrhea with symptoms first, then she developed pain abdomen, which will give us idea that, okay, so the triad is different here, right? So pain abdomen, when it comes first, followed by vaginal bleeding, we will think differently. But when we go to her history of first trimester, so then we come to know that, okay, so the bleeding pattern was for the abortion was normal. So she developed amenorrhea. Then I come to know that around 8+ weeks of pregnancy, she developed bleeding per vaginum, which was painless and scanty, for which she was she visited hospital, and then from hospital she was provided with some medical and advised for the bed rest. So after that, after 2 weeks of this episode of bleeding, again, then she started having problem at her 10 plus weeks of pregnancy. So how the problem began was, so initially with the pain abdomen, which was dull aching, but later on it was increasing in intensity, so becomes colicky, and this pain was associated with the bleeding. So nature of bleeding that Iwa explained was, which was increasing fresh bleeding, increasing in amount with the passage of the clot. Yeah, so this is directing us that the sequence has been maintained. So there was amenorrhea, there was pervaginal bleeding, and there was pain abdomen. Okay, so we can make out that maybe this is a case of abortion, but still we do not know what is the case. Okay, now I would like to proceed on with the differential diagnosis. So when history, like certain so beginning, very beginning, so there was history like certain abortion, because at her 8 weeks of gestation she has amenorrhea, she has painless scanty bleeding per vaginum, and for which she attended medical care, and then she was told that everything is all right and given some medication. Okay, maybe extra medication. I think she has also mentioned the name of the medication, most probably progesterone. We don't know. But she was also given, apart from the folic acid, she was also given some additional medicine and asked for the rest. So which indicates that maybe she was diagnosed as a case of threatened abortion during that time. Okay. Now, so differential diagnosis, whenever somebody, okay, some pregnant women at the first 3 months of the pregnancy will complain of PV bleeding or pain abdomen. What are the different things that we should have in our mind? Okay, so there are various types of abortion. So it is not only with the abortion, it may be molar, it may be ectopic, it may be pregnancy with bleeding because of some genital tract problem, okay, maybe infection or maybe, okay, trauma, whatever. But again, when we say abortion, again, it is not limited only with the, so we will discuss only with the some particular abortion, but we have to have idea of differential diagnosis and how we can come to the particular case, okay, that is the provisional diagnosis. So when we talk about amenorrhea, PV bleeding, and pain abdomen, so the abortions that can be there can be threatened abortion, inevitable abortion, incomplete abortion, complete abortion, missed abortion, septic abortion, recurrent abortion. So these all, so abortion and other, so we have already mentioned that it may be pregnancy associated, okay, not abortion, but maybe molar, ectopic. So these can be there. Now, how will we proceed with the history? So what are the things we have to ask is, okay, so how certain abortion will present? So when we say there is, so when we discuss, we will be discussing about amenorrhea, right? So amenorrhea, when we explain, so we have to, it is not only limited with the amenorrhea only. So if it is pregnancy and amenorrhea because of the pregnancy, so it must come with some of the pregnancy related symptoms. So when we say pregnancy related symptoms, it is just simply, it can simply be morning sickness, okay, fatigue, breast tenderness, okay, and increase in the frequency of maturation. So these symptoms will be there with the amenorrhea. Now, when we discuss about somebody will complain about bleeding, okay, so as a medical person, as a medical student, so you should not only be limited with the bleeding, but we should try to find out the nature of the bleeding. So in every case, so I have written almost points 1, 2, 3, 4, 5, 6, 7, 8, 9 points here. Okay. So in 9 different conditions, the bleeding pattern is different. So this you have to identify, and you just don't write that, okay, she has a bleeding. So what you have to do is you have to try to understand the type of bleeding. See, what will happen in threatened abortion? So if there is threatened abortion, there will be scanty fresh bleeding. So most of the time, so this scanty amount of bleeding is not associated with pain abdomen. So when you take history, you should try to understand, okay, you kasto khalko hota, okay? So threatened abortion will be like that. Now, in case of the inevitable abortion, so I'm sure I don't have to go through all these definitions of it. I think I should go definition. So threatened abortion, when we say threatened abortion, that means there is threat for the abortion. So the conceptus inside the uterus, so trying to threat the mother that if you don't take care of me, I'm going to come out. So that is the threatened abortion. I know. So threatened abortion, so can continue, pregnancy can continue, or it can be converted into other type of abortion. Now come to the inevitable abortion. So inevitable, when it comes to the inevitable abortion, I would like to again take you back to the threatened abortion. So threatened abortion, there is a threat, but in inevitable abortion, you can take it continuously, okay? In inevitable abortion, what will happen is, now, even if mother will do something to the fetus, it is not going to get continued. The pregnancy is not going to get continued. So somehow it will end up. Okay, pregnancy will end up. So this situation is considered as inevitable abortion. Now come to the incomplete abortion. So what is incomplete abortion? Means now again I'm relating this to the from the beginning, from the threatened to inevitable, now inevitable to the incomplete. So again, if you don't give care for the inevitable abortion, or even if you give care to the inevitable abortion, what is going to happen is slowly the product of conception that is going to come out from the uterus via vagina. So incomplete abortion is the time in between complete and inevitable. So some products are still remaining, some are outside. So people, they will get very confused with the inevitable and incomplete. So in inevitable abortion, the process of abortion already established to one extent so that it cannot revert back. But the process of the product of conception coming out from the uterus has not started yet. But in case of the incomplete abortion, the product of conception now started coming out from the uterus. That is what is the basic difference in between the inevitable abortion and incomplete abortion. Now, complete abortion, I don't think I have to explain everything. So everything has come out. So it is complete. Now, missed abortion. What is missed abortion? So missed abortion, what is missing in the missed abortion is the cardiac activity. So without notice of mother, to the cardiac, there is already the fetal demise has been taken place. Okay, so when we talk about abortion, so it is up to 20 weeks, we all know. Okay, so septic abortion is the abortion. So any type of abortion complicated with sepsis is the septic, it becomes septic abortion. So recurrent abortion is the terminology, so we utilize this. So when there is spontaneous abortion more than 3 times because of different cause, so recurrent means more than 3 times recurrent. So this is recurrent, you know. So ectopic, you know, ectopic. So when the implantation happens beyond uterine cavity, we call it ectopic pregnancy. Okay. So molar is pregnancy-associated condition where grapes-like vesicles will grow inside the uterine cavity. Okay, so now, so these different types terminologies here utilize different conditions. They will have different nature of bleeding. Okay, so just I have explained about the threatened abortion. So it is bleeding, scanty bleeding, fresh bleeding without association with the pain abdomen. So when there is bleeding, so it is not only the nature of bleeding you have to ask, but also you have to ask the different associations. Okay, so that you can come near the differential, you can exclude the differential diagnosis and come very near to your diagnosis. Okay. Now, what will be the change in inevitable abortion? So in case of the inevitable abortion, that scanty fresh bleeding which was started in the beginning, so it will turn different. Okay, so the bleeding will become excessive bleeding. Okay, there is a fresh excessive bleeding with the passage of the clot. Okay, and this excessive bleeding will be associated with the pain abdomen because of the uterine contraction. Okay, cramps will be associated with the pain abdomen. Now, so then what is different in incomplete abortion? So in incomplete abortion, inevitable abortion plus what will be there is the product of conception. So she will complain that she has also passed few fleshy mass, okay, few chunks of the fleshy mass. So excessive bleeding will be there, clot will be there, passage of the fleshy mass will be there, okay, and pain abdomen will be there. So when you ask about the bleeding, so you have to ask, okay, have you passed? Clot beneath you, or was there a fleshy mass? Was there a grapes-like vesicles? Was there what is there? Okay. Now, complete abortion. So how will you identify complete abortion? By history. So she will give history, past history of abortion. So she will have all these three. Okay, certain go, inevitable, incomplete go. All features will be there at the end. When after passing of the fleshy mass, she will get relief of bleeding and pain. So this is the sign of the complete abortion. Okay. Now, missed abortion, I have mentioned that the fetal demise has already taken place. Okay. But patient, mother is unaware of it. So there will be bleeding inside and that old blood will come out per vagina. So this will be when, so sometimes patient may complain, okay, dirty discharge per vagina. Sometimes when we will see dirty discharge. So dirty means it is like mud-like discharge, muddy discharge. So when muddy discharge is there, you have to know that it is old clot that is coming out. Okay. So if it is there, then maybe you have to think that this is missed abortion. Septic abortion is because of the complication with the sepsis. So when we say sepsis, so sepsis is recognized by foul smelling discharge, blood-stained discharge per vagina. So in other type of abortion, we will not get foul smelling discharge. But in the septic abortion, yes. Also, it is associated with the, maybe she will complain of fever. Okay. So recurrent abortion, I think it depends upon the type. So there are different causes for the recurrent abortion. But if somebody is complaining you of passage of product of conception in total, okay, in one chunk with very minimal pain, so you have to think of cervical incompetence. Okay. Now, ectopic, how you are going to get differential is in ectopic there will be scanty dark bleeding. See? In threatened, scanty fresh bleeding. Ectopic, scanty dark bleeding. Threatened without pain abdomen. Ectopic with pain abdomen. So pain abdomen comes first before bleeding in ectopic. So the triad is like amenorrhea, pain abdomen, baby bleeding in ectopic. In other abortion, amenorrhea, okay, bleeding, and then pain abdomen. Third. So molar is when somebody will complain you of molar bleeding. So it will be dark color blood. Okay, dark blood. So usually patiently vesicle pass directly, they will not give history like that. But okay, if give history, then it will be dark blood with vesicles inside. So history, are you clear? Do you have any question up to here? To the chat box here, Sula. So terminology, yes. So terminology, miscarriage and abortion, it is the synonym. Okay. Any other question? So there are different causes of abortion. Okay. So I have to say that mostly almost 50% of the abortion that is happening without notice of the mother. Okay, so that is the biochemical, we call it biochemical pregnancy. So that happens with almost like 50% of this without mother to notice. Now it is going, okay, terminating abortion, but without not notice to the mother. So different, when you see the different causes of abortion, so very common one is the chromosomal abnormalities. So the one that is going to be abnormal in the future, so they will get aborted very soon. Okay, multifocal pregnancy, these are the fetal caused by and maternal infection, maternal medical disorders, hormonal abnormality. Okay, we will come to this later on. Maternal immunology, uterine factors. That these different, these are the causes of abortion. Okay? Now again, I'm going back to our history, Azago history. Okay? So when Iwa mentioned that her vitals was stable, almost I can make out that except for the pulse was 90, but everything was normal. I know. Again, when you, so after she presented history, so you follow one pattern. I know. There will be history, there will be examination. So in examination, you will start with general examination. So general examination, especially with the vitals. What will be the change in the vitals? Okay. Now I'm taking you back to my previous slide. If you have noticed my previous slide, isma herni ho bhane. So in inevitable abortion, incomplete abortion, septic abortion, ectopic and molar, I have put one sign. I know. And this sign is important. It is because so these are the conditions mentioned in the obstetric emergency. So that can create obstetric emergency. So when we say obstetric emergency, then that means these situations can give rise to the maternal death. Anuko matlab, these conditions, okay, so mother can bleed torrentially so that she can bleed to death. I know. So this has to be taken within maternal obstetric emergency. Okay. So it becomes important in vitals. I know. So threatened abortion. So you do not, when there is a scanty amount of bleeding, okay, without pain, so you do not expect there will be any change in the, okay, vitals and general examination. So in inevitable abortion, incomplete abortion, okay, ectopic pregnancy and molar, so they may present with the features of shock. Okay, even if they do not present with the features of shock, so they may have tachycardia, they may have, okay, low blood pressure. Okay, in case of the septic abortion, they may have temperature, raised temperature, hyperthermia, or they may present to you with hypothermia because of the features of the septic shock. Okay. So molar pregnancy, if it is not bleeding, so bleeding bhayeko chaina bhane, so molar can present with hypertension because it is one of the conditions where the hypertensive features can come before 20 weeks of gestation. So there may be features of thyroid toxicity. I know. So very particular of 4 with the features of stroke, molar with hypertension and thyroid, and other, say for example, threatened, okay, complete abortion, okay, and missed abortion. So they present to you mostly with the, okay, stable vitals, okay. Now then, when you do general examination, I know, so general examination, oral examination you will do apart from the vitals, I know. So now, मैले अगाडि पनि भने के त भन्दाखेरि, so molar pregnancy ma thyroid talk भनेपछि you have to examine the thyroid, you have to examine, see for the, okay, tremor, okay, this is must. Now, abdominal examination, I know. So abdominal, when one must understand when we discuss about abortion, so it is up to 20 weeks of gestation. So uterus becomes palpable only after 12 weeks of pregnancy, you know. So threatened abortion ma usually abdominal examination, it will be normal, okay. If it is more than 12 weeks of gestation, so height of the uterus will corresponds to the period of gestation. Inabitable abortion, okay, if it is there, then there will be tenderness in the lower abdomen. Fundal height will be corresponding to the period of gestation because almost all product of conception is still inside the uterine cavity, you know. Now, in incomplete abortion, there will be tender abdomen, okay, tender abdomen, and the fundal height is less than period of gestation. It is because some of the product of conception has already come out of the uterus, okay. Now, complete abortion ma ke huncha ta bhandakeri, now the tenderness will be gone. So, all the product of conception is already out. Now, there will be the no bleeding, no pain, okay, but fundal of height will be less than period of gestation. In missed abortion, we don't know when the fetal demise has taken place. So, again, on examination, there will not be tenderness, but fundal height will be less than period of gestation. I know. Septic abortion, it varies depending upon the time. Okay, the time of presentation. So most of the time, it will be tender abdomen, maybe generalized tenderness. Okay, and it depends. The size of the uterus depends upon the amount of the product of conception that is remaining inside. So recurrent abortion, because it varies because of different cause, so we will not discuss about the recurrent abortion. So in ectopic pregnancy, so what will be very different from the abortion is because in abortion, bleeding from the uterus will come out. In ectopic pregnancy, bleeding will be accumulated inside the abdominal cavity and it will irritate the peritoneal cavity. So there will be distension of the abdomen, and if you palpate, there will be tenderness with the rebound tenderness. Okay, molar is very different. So because the molar tissue, they are very rapidly progressing. Okay, rapid growth. So because of that, she will have tender abdomen, tender on palpation. Okay, and height of the uterus is more than period of gestation. Okay, and when you feel it, it will be very soft like a dough. So if we relate back to Iwa's history, So I can make out that her abdomen was tender and fundal height was corresponding to the period of gestation. Okay. Now, examination. Different types of abortion, ectopic, molar, and speculum examination. What will be the difference? Okay. Now, in threatened abortion, when we say pelvic examination, so we will follow order. Order means first speculum examination, followed by the digital examination. Okay. So first we are doing speculum examination. So in case of the threatened abortion, if you put the speculum and see, then you'll come to know that os will be closed, scanty fresh bleeding per vagina. You will be finding scanty fresh bleeding per vagina. Right? So os will be closed. This is very important. Okay, the condition of the os is very important because that specific point is going to give you the clue. I mean, what will be her management? Okay, inevitable abortion. So I remember Iwa saying os open, okay, and there is a active bleeding was there. So similar to that, in inevitable abortion, os open, active bleeding with the passage of clot. Incomplete abortion, os open, okay, sometimes together with the active bleeding, passage of the clot. When you put speculum, what you are going to see is you are going to see the product of conception either lying in the vagina or hanging from the cervix. Okay, so it is partially coming out, or sometimes when you put speculum, it will come out on its own, not hanging by the head. So this will be the feature in case of the incomplete abortion. Complete abortion, so when products of conception all expelled, what will happen is the os will be closed and you will see only, you will not see any active bleeding in complete abortion. So you will see the blood stain discharge. Okay. So missed abortion, as I have explained, os will be closed. Okay, and there will be the dirty discharge per vagina. Septic abortion, so os will be closed. So there will be the foul smelling pus-like discharge. Okay, pus-like discharge. Ectopic os will close and there will be the scanty blood stain discharge. Okay, molar most of the time, if not aborting, then os will be closed. Okay, if open, aborting, then if open, os will be open, then there will be the dark, carry blood. So with vesicles will be, you can see the vesicles coming out. So this is what is the different picture with speculum. Every different types of abortion. So I'm going very practically telling you all this. What will be the change in every types of abortion? What will be there in ectopic? What will be there in molar? Now, this is not very different from the previous one. So threatened abortion, what will be there is when you do internal examination, that is digital examination. So height of the uterus will be equal to the period of gestation without pain. Inevitable abortion height of the uterus equal to the period of gestation. So Iwa also mentioned that she can feel product of conception from her finger. Okay, so incomplete height of the uterus will be okay. Just inevitable abortion, just in case, it can height of the uterus can slightly increase also because of the collection of the clot. Okay, incomplete abortion because partially product of conception now already started coming out, so it may be less than period of gestation. So complete abortion, so it is painful though, so tender also digital examination. Complete abortion height of the uterus will be less than period of gestation. Missed abortion I have already mentioned, kita bandahari just recently missed by kusfabani. Okay, recent demise maybe height of the uterus is not altered, but yes, if missed abortion has taken place few months or few weeks earlier, then definitely the height of the uterus will be less than period of gestation. So septic abortion, or what is going to be different is septic abortion is abortion complicated with the sepsis. So height of the uterus depends upon the amount of product of conception. So uterus will be tender. So when you put your finger inside, visit inside our vagina, it will be hot vagina. Okay, dry sometimes, and then tender. So this will be the features of the septic abortion. Okay, now ectopic yes, height of the uterus is definitely less than period of gestation. Uterus will be bulky because of the hormonal change and the blood supply. Okay, and very particular about ectopic is there will be the cervical motion tenderness. Molar pregnancy height of the uterus is more than period of the gestation. Okay, so this is how this differential diagnosis is getting differentiated in terms of abdominal examination, in terms of the speculum examination, and in terms of the digital examination. I know. Now, how you are going to get diagnosis? So differential diagnosis is already there. I know. So diagnosis kasari गर्ने त भन्दाखेरि, yes, I know you are going to do it. This is actually the summary. I know. So I think I will do. I'm going to tell this later on rather than. So certain abortion. I know. So how you are going to get the diagnosis? So certain abortion. So the first picture here. So this is the threaten. So the still. By doing ultrasound, you will come to know in certain abortion, you will see the cardiac activity. Okay, so apart from the history and examination, when you do sonography, you will get the cardiac activity. So cardiac activity present, that becomes certain abortion. Cardiac activity absent, then that becomes missed abortion. Okay, well, so it is very good to know that. So this is ultrasound picture. Gestational sac, yolk sac is there. So but यसमा चाहिँ के त भन्दाखेरि to very typically certain abortion देखाउनको लागि cardiac activity यसमा देखाएको छैन. But what you can see is, you can see the arrow that is showing the hypoechoic area. So that is the subchorionic hemorrhage. So nowadays, it is certain abortion can also get diagnosis on the basis of the ultrasound. So if you can see the subchorionic hemorrhage, so you can measure that. Depending upon that, you can divide whether this is the mild, moderate, or severe subchorionic hemorrhage. You can also make out if this pregnancy is going to continue or not. So more than 3 centimeter subchorionic hemorrhage size, more than 3 centimeter has not very good prognosis. So here the management so but I would like to go to the diagnosis first, so before management. So inevitable abortion. So now from history, what will be the history. Okay, what will be the nature of bleeding, what will be the examination finding, so in inevitable abortion, so when you do ultrasonography, what you will see is, see very nice gestational sac in the ultrasound. So there is presence of the clot all around the gestational sac. So, I mean, it is almost, the product of conception is almost separated from the uterine cavity. So that means it is not going to continue at all. So this is inevitable abortion. I know. Now just focus, I want you all to focus only on your investigation. Right? So incomplete abortion ma, I know. So see, you can see some of the hypoechoic white areas, I know. So this is your hypoechoic areas. These are the product of conception. Some of the products of conception are remaining inside the uterine cavity. So some maybe already passed. So this is the incomplete abortion. So in case of the complete abortion, you see, if you compare the previous ultrasound picture, so this is incomplete abortion. So with the some clot, yeah, okay. So this is, I know, okay, some fluid, I know, clot. So this is product of conception. Now, everything gone, I know, out. So the endometrium, I know, is so thin. So thin, you know, so nothing remaining inside the uterine cavity. I know. But see, the cervix is so vascular. Black areas are the cervix. I know. So this is the complete abortion. Missed abortion. I know. So fetal demise has already taken place. Even if so, you put Doppler. I know Doppler you cannot predict the fetal heart sound. So this is what you are going to get in case of the missed abortion. I know. Septic abortion na I told you depends upon the product amount of the product of conception. Even if product of conception is not there, so the picture is showing that there is some collection inside the uterine cavity. So maybe the fluid, maybe the pus, okay, may get collected inside the uterine cavity. Recurrent abortion, this is very nice picture, I know. यसमा चाहिँ के देखाएको छ त भन्दाखेरि so cervix, I know. Sorry, so T, I know, okay, that is the Y, okay, U and V. I mean, cervix is getting short, and if the T is okay, I know. So V, Y, dilatation up, dilatation has gone down, and dilatation completely. So this is what you are going to get in case of the recurrent abortion if it is due to cervical incompetence. I know. Well, I'm going back to this slide now. I know. So this is the summary of the diagnostic. What is diagnostic of certain abortion? Is scanty bleeding with cardiac activity, okay, or you may see the subchorionic hemorrhage in sonography. In case of the inevitable abortion, excessive bleeding with the passage of the clot, also will be open, ultrasound showing product conception with clot inside the uterine cavity. Incomplete abortion excessive bleeding with the passage of the clot and passage of the product of conception. Okay, also will be open and ultrasound showing some of the product of conception remaining inside the uterine cavity. Complete abortion, there will be history of pregnancy, then there will be history of the passage of product of conception, and now bleeding subsiding. So in ultrasound, there will be the uterine cavity will be empty. Missed abortion, okay, so there will be the amenorrhea and there will be the subsidence of the symptoms of the early pregnancy, height of the uterus, less than period of gestation, examination ma, dirty discharge with os closed, PV ma ke huncha ta bhandakeri absence of the cardiac, ultrasound ma there will be the absence of the cardiac activity. Septic abortion ma, so pregnancy, maybe history of abortion, maybe history of the medical termination or surgical termination of the pregnancy with के हुन्छ त swinging rise of temperature with foul smelling discharge per vagina. So recurrent abortion ma, so history of the previous more than 3 abortion. Ectopic pregnancy ma के त भन्दाखेरि amenorrhea, pain abdomen, baby bleeding, ultrasound ma uterine cavity will be empty, gestational sac के हुन्छ त outside the uterine cavity, and in abdominal cavity you will be identifying the free fluid. So this is what will be the diagnostic of ectopic pregnancy. Molar pregnancy ma amenorrhea huncha, exaggerated symptoms of pregnancy huncha, abdomen ma ke huncha ta height of the uterus will be more than period of gestation, and ke huncha ta भन्दाखेरि ultrasound ma grapes like vesicles huncha inside the uterine cavity, that is giving rise to the snowstorm like appearance, and on the side of the abdomen ma ke huncha, uterus ma ke huncha ta hugely distended ovaries because of the paralysis huncha. If you do the serum beta HCG, it will be very high, beta HCG. So that is the tumor marker for the molar. Okay, so this is how we are going to get diagnosis. So I'd like to break एकछिनको लागि. So if you have any questions, so I'm going to open the chat box. Which one is considered as criminal abortion? Okay, criminal abortion भनेको चाहिँ usually see abortion को law सबै country मा every country मा abortion cannot be done legally. So illegally जुन country मा illegal भएको छैन, so त्यो country मा they can consider abortion as a criminal, So हाम्रो नेपालमा पनि 2002 मा so the law त्यति बेला मात्र आएको हो. त्यो भन्दा अगाडि सबैजनाले लुकी लुकी नै abortion गर्थ्यो, ओके. अहिलेसम्म पनि के छ त भन्दाखेरि except so 12 weeks सम्म मात्र limitation दिएको छ. Okay, so 12 weeks भन्दा beyond, so if abortion is done, so it has to be some indication, okay, either maternal indication or fetal indication. So 12 weeks भन्दा beyond कोही मान्छेले sex detection गरेर abortion गर्न गयो भने पनि तिनीहरूलाई समात्न मिल्छ. So this will also be considered as a criminal abortion, So I'm going to take another question. यो भन्दा माथि जाँदैछु. Well, tranexamic acid, drug of choice in excessive bleeding following abortion. So tranexamic acid, drug of choice त नभनौं. So I would like to, so I will be explaining this later if you don't mind, because we have not gone through the management. So, but if I don't, please remind me. Okay, so again the criminal one. Okay, gravida र para को कुरा आएको छ. So by definition you should not be confusing, So she, every time she conceives, so the number of the pregnancy, is the gravida. Number of the times she will be going to give birth after the period of viability, so that will be carried in the para, Well, very good question. So Sushil. So Sushil is asking me, can scanty fresh bleeding without pain abdomen be due to implantation bleeding? Well, yes, of course, yes. I'm very happy that he brought up this point. So when we first started discussing about bleeding, so it was, I jumped into the pathological bleeding directly without any giving explanation for the physiological bleeding. Yes. So physiological bleeding can also be there at the very beginning of the pregnancy. So ovulation, it will take place 14 plus minus 2 days. So it has to go to the fallopian tube and fertilize, and then from there it has to be carried to the uterine cavity. You know? So tube will work so that tubal motility, tubal, it will function so that it will be able to deliver this zygote to the uterine cavity. So uterine cavity सम्म पुग्दाखेरि it will take 5 days. 5 days सम्म हुँदाखेरि के हुन्छ त भन्दाखेरि it will be 2 cell stage, 4 cell stage, morula, and then blastocyst मा change हुन्छ है. So at the stage of morula, it will be entering the uterine cavity. So on the 6th day, zona pellucida will disappear and then implantation will take place on 6th day. भनेपछि 14 plus 6, 15, 16, 17, 18, 19, 20, 21. भनेपछि 20, 21, 22 days को वरिपरि के हुन्छ त भन्दाखेरि women, they may have scanty fresh bleeding because of the implantation. So you have to take, so it may get confused with the LMP. But how you have to take history is, okay, what was the nature of bleeding? So was it in the same day like the previous menstrual cycle? So if you calculate, it is slightly almost a week before menstrual cycle, regular menstrual cycle. Okay, so this may not be irregular menstrual cycle. We may not be able to identify this implantation bleeding. Have I made you clear, Sushil? The other question was, could there be a confusion between large chunk of clot and mass? To confuse between inevitable and incomplete. Okay. So, this is from the pre-maternal, see, I will be explaining this in context to 2 points. The first point is incomplete abortion. Incomplete abortion ma, if I have already explained everything, that there will be amenorrhea, there will be PV bleeding associated with the passage of clot, and the product of conception will come out in piecemeal, tukra gareर निस्किन्छ, incomplete abortion. Okay, and it will be associated with this pain abdomen, colicky pain, dysmenorrhea type of cramping colicky pain. Okay, now how you are going to get differentiated that from the inevitable? Again, inevitable because of the cervical incompetence. Usually, कुन time मा हुन्छ त भन्दाखेरि either late first trimester or beginning of the second trimester मा हुन्छ. So when the membrane, fetal membrane, amnion and chorion will come and stick, so the pressure will be down. So pressure down हुने बित्तिकै नै के हुन्छ त भन्दाखेरि, so it will be separated and it will come out. Usually pain किन हुन्छ? Pain is because uterus is contracting, cervix need dilatation in response to the uterine contraction. So there will be the pain, dual plane, uterine contraction or cervical dilatation. So cervix when already dilated, uterus need not to do much exhaustion. So minimal uterine contraction already dilated cervix in toto, sac, okay, it will come out in chunk. Okay, this is how I think have I made you clear? Prick matra छ name ओले पनि हुन्छ है. Have I made you clear? So I'm going to take are the miscarriage you can basically, so I'm going down, so I'm going to the physiological. How can we distinguish whether it is physiological bleeding or pathological bleeding? Well, physiological bleeding is just a stain without pain. stain matra huncha, okay, few drops. So if you compare physiological bleeding with threatened abortion, the amount of bleeding in threatened abortion is quite large in amount, okay, than the physiological bleeding. Okay, so if you don't have any, so you can keep on texting me, I know. So I'm going to close this chat box. I'm going to brief about the management. I'm not going to brief very deeply, एकदम elaboration चाहिँ म जाँदैन, just so that you can understand every details के गर्दो रहेछ त भनेर you will be able to make out. Okay, so this is how I'm going to make you clear about today's case presentation. हैन, so till now, so as per her case, so we can make out there was bleeding, so there was pain abdomen, there was PV bleeding, I know, but according to that, it is not. Now we can say, so we can say that this is not a case of ectopic, even if the chief complaint is suggesting us that it may be ectopic because amenorrhea, pain abdomen first, and then PV bleeding. But when she explained about history of first trimester, we can make out that the bleeding came first before pain. Okay, bleeding, it was scanty, painless, but later on it changed its nature. So threatened bara, it went into the inevitable abortion. Okay, so up to here clear boy any case bara. So this is inevitable abortion, right? I know. Okay, now we are going to the management. I know. So if you have any questions still, so you can keep on texting, I know, so that we can have discussion later. Management of threatened abortion. See, I told you threatened abortion. So when we think about management, we have to think about the cause. So what is the cause for the threatened abortion? I know. See, cheese that is coming inside the uterus, whether this is sperm hose, whether this is product of conception, zygote, okay, blastocyst hose, अथवा polyp hose, अथवा fibroid hose, whatever that comes inside the uterine cavity, it will try to expel it out, thinking that this is the foreign body for the uterus. Okay, I know. Okay, including our intrauterine device. I know. So, जुन चीज uterine cavity भित्र आउँछ, uterus tends to expel. I know. So, because of the different chemicals that is coming out as a product of the pregnancy, so it is going to protect the fetus. I know. So the very much protection is done by the hormone itself. I know, human chorionic gonadotrophin and the progesterone. So pregnancy hormone is the progesterone. I know. So this is going to give recognition that pregnancy SCG wala tha huncha. SCG is going to support pregnancy like beginning support until and unless placenta is established. So I know. त्यहाँबाट यो आउँछ त भन्दाखेरि सेन्सिटिभ टु प्लास्टबाट आउँछ हैन. ओके, त्यो भन्दा अगाडि हैन, सो प्लस यिनीहरु बन्नु भन्दा अगाडि हार्मोन कहाँबाट आउँछ त भन्दाखेरि कर्पस ल्युटियमबाट आउँछ हैन. सो कर्पस ल्युटियम इज गोइङ टु सपोर्ट the pregnancy until tropoblastic activity becomes very stable हैन. ओके, भनेपछि the main कुन बेला हुन्छ त यो भन्दाखेरि कर्पस ल्युटियम क्यान फंक्सन भेरी वेल अप टु 9 वीक्स सम्म मजाले काम गर्छ हैन. न त उसले 10-11 वीक्स सम्म पनि अलिकति हार्मोन त दिइरहेको हुन्छ, बट बाइ द टाइम के हुन्छ त भन्दाखेरि प्लासेन्टा विल टेक ओभर द फंक्सन हैन. ओके, प्लासेन्टा विल टेक ओभर द फंक्सन भन्नुको मतलब प्लासेन्टाले हार्मोन सेक्रेट गर्न थाल्छ. सो यो ह्यान्डओभर र टेक ओभरको टाइम इज अराउन्ड 8 वीक्स. If you just go back to your clinical practice, जुन बेला तिम्रो clinical practice मा जान्छौ, if you see most of the threatened abortion, it happens around 8 weeks of gestation, because any cause that is going to disturb the hormonal function is going to give rise to a threatened abortion. So very common cause is the corpus luteum insufficiency. होइन corpus luteum ले sufficient time सम्म hormone secrete गर्नु पर्नेमा somehow त्यसले अलि अगाडि गिभ अप गर्यो भने प्लासेन्टाको फंक्शन स्टार्ट हुनु भन्दा अगाडि गिभ अप गर्यो भने त्यसले के हुन्छ त थ्रेटन अबोर्सन हुन्छ हैन ओके भनेपछि व्हाट इज द म्यानेजमेन्ट सो अलमोस्ट भन्नु पर्दाखेरि 40% 30% 30 to 40% मा के हुन्छ त भन्दाखेरि knowingly or unknowingly threaten happening हैन बट म्यानेजमेन्ट के हो त भन्दाखेरि बेसिक म्यानेजमेन्ट इज द रेस्ट ओके रेस्ट है and rest पनि rest कस्तो rest भयो हैन so means so once appearance of blood भइसकेपछि so at least 48 to 72 hours complete bed rest and after that there is the के त भन्दाखेरि bed rest मात्र हैन so absolute bed rest र bed rest मा फरक छ absolute bed rest भनेको with the provision of the bedpan itself so at least 42 to 72 48 by 72 hours then she need absolute bed rest okay hormonal support so though many books ma you will not get it I know hormonal support it is not functioning giving the actual management भने त्यति support गरेको छैन but we know that this is because of the hormonal deficiency so hormonal support if we can provide by giving some of the hormones say for example beta hCG or micronized progesterone so this is going to help I know or alpha hydroxy progesterone so this is going to support the pregnancy so this is the management of threatened abortion so inevitable abortion I know so this is obstetric emergency like we have mentioned that this is the obstetric emergency so whenever we talk about obstetric emergency ko kura गर्ने बित्तिकै you have to resuscitate the patient I know so resuscitation shock management so I'm not going to go detail about resuscitation and shock management so there may be need for the resuscitation so inevitable abortion ma if you go back to the speculum examination us open भन्ने बित्तिकै नै के त भन्दाखेरि so if you are going to provide with the surgical management then you do not need to dilate the cervix because the cervix is already dilated so what you have to do is you have to go directly to the suction evacuation if it is less than 12 weeks of gestation I know well more than 12 weeks of gestation भयो भने के गर्ने त हैन so you have to go for the medical termination well here even for the less than 12 weeks of gestation you can go for the medical termination nowadays we have availability of the mifepristone and misoprostol but you have to consider the situation of the patient if the patient situations or vitals are stable so there is no need of resuscitation yes you can go for the misoprostol okay yeah but if vitals are not stable I know so she's in a state of shock so you have to go for the surgical okay because you have to complete the treatment quickly okay rather than letting her go into the worst situation so every abortion so because we do not know the patient blood group and all I know so if RH negative so you have to give anti-D I know so antibiotics prophylaxis I will say it is necessary I know because pregnancy and abortion that means she need pregnancy okay in future so to protect tubes and all from the sepsis so we have to give antibiotics again we have to protect inevitable abortion from going into the septic abortion so tetanus toxoid depending upon the need okay so have I made you clear about the inevitable abortion so I'll jump to the incomplete abortion again it is not very different from that of the inevitable abortion so less than 12 weeks suction evacuation because you do not need to dilate you are not doing dilatation and evacuation you are doing suction evacuation if it is less than 12 weeks of gestation so inevitable banda incomplete abortion there is chance that there is need for the resuscitation okay so more than 12 weeks you are not going to do it by surgical route so you follow the medical termination because More than 12 weeks of gestation ma ke huncha, uterus becomes very soft, thin, and with there is chance of surgical complication. So okay, so you buy. Well, I want to add here is use of the ovum forceps. So you must have heard of ovum forceps. Ovum forceps is, I do not have picture here, ovum forceps is, the name is ovum forceps, but this is not for picking up ovum, because you cannot pick up ovum from the ovum forceps. So this is, with the help of ovum forceps, you are going to take out the product of conception that is hanging from the cervix. Okay, again, you are not going to introduce this ovum forceps inside the uterine cavity and pull the product of conception out. It is only meant to take out the product of conception that you can see from your naked eye from the examination. So complete abortion is, actually the specific management is not needed, but recently incomplete I could harmony, there may be need for the resuscitation, maybe need for the prophylactic antibiotics, okay, and the other missed abortion. Okay, so this is what you have to understand, right? So till now, inevitable incomplete, the os was open, so the surgical management of what was being done is the suction evacuation, well, suction evacuation ko kura garnu parदाखेरि pani you can do it with the help of manual vacuum aspiration, and you can also do it with the help of the suction, okay, machine ma rakhna pani sakiन्छ. So missed abortion ma, again, if it is less than 12 weeks of gestation, so less than 12 weeks of gestation छ भने, see the term mentioned is the dilatation and evacuation, right? Why this dilatation and evacuation? Because in missed abortion, the os is closed. Os closed ma, you need dilatation and you need evacuation. So this is why there is a dilatation and evacuation in case of the missed abortion. More than 12 weeks, medical termination. Because in case of the missed abortion, it is not medical obstetric emergency. So here, even if it is less than 12 weeks of gestation, you can choose for the medical termination by giving mifepristone, okay, and misoprostol. Septic abortion is very different from that of the others, so it will give you a very confused condition, septic abortion ma sepsis maybe it is coming from the extra, body ko different part ma sepsis bada uterus ma chireko pani huna sakcha, or uterus ko bhitra ko product of conception is functioning like a foci. You don't know. But there is sepsis, okay. Now septic abortion ko lagi अर्को difficulty is antiseptic coverage, okay, because we have to prevent patient from septic shock, so we have to give broad spectrum antibiotic coverage, if possible 48 hours, if not 12 hours, if not then 6 hours. Septic coverage by giving broad spectrum antibiotic should be done before you touch patient. Touch भन्नुको मतलब you have to take out the foci. Incomplete abortion को foci, uterus भित्रको foci त निकाल्नु पर्यो. So before you touch the patient, you have to give the antiseptic coverage. And why this is needed? It is because the uterus, which is very, very ill uterus, okay, ill uterus will refuse to contract, refuse to retract, refuse to contract. So she is not dying because of the sepsis, but she is dying because of the profuse bleeding if you do not give antiseptic coverage before. Okay. Now, so this is one condition for the septic abortion. The other condition, patient may land up to you with septic abortion with bleeding. In such situation, what are you going to do? So are you going to follow like I have mentioned, like you wait for 48 hours, if not 12 hours, if not 6 hours? No, because the patient is dying in front of you if you do not manage her spontaneous immediately. So in such condition, you have to remove the foci, okay, and try all the measures that to stop the bleeding from the uterus. I remember one incident where I stayed standing for more than 1 hour. Septic abortion bleeding with you. So I was with our second batch resident. So I was standing, even not in the operation theater, but I have taken her to the procedure room because she was bleeding at the time of presentation. So almost 1.5 hours you try and massage internal massage all the medicine just after 1.5 hours she stopped bleeding. And I was able to save the patient. So this can happen. Okay, so the septic abortion is quite confusing, but you should know it. If not bleeding, why not give antibiotic coverage first, followed by the removal of the septic foci? But sometimes if somebody comes to you with the bleeding, okay, she will bleed to death. So in such condition, so you have to utilize almost all measures you have. Yes, say for example, Tranexa. Usually we are giving what? We are giving all the uterotonics. So apart from all the uterotonics, yes, there is role of tranexamic in case of the stopping the bleeding. But the tranexamic company, it is not going to act immediately. So at least it is going to take at least 15 to 20 minutes to act. So recurrent abortion, the management depends upon the cause. So one of the very common one is yes, because of the anomaly or cervical incompetence. So you have to give pre-pregnancy condition को manage गर्नुपर्ने हुन्छ केही pregnant भयो भने cervical surplus गर्नुपर्ने हुन्छ. So but if it is because of other cause, chromosomal abnormality हो कि medical disorder हो कि maternal immunology related condition हो कि maternal infection हो कि, okay, so you have to identify hormonal disorder हो कि. So depending upon the cause, so we have to investigate in line of all these to identify from the time of previous recurrent abortion, पहिला 3 abortion भइसकेपछि मात्र we will try to investigate. So nowadays, can we wait for 3 abortions to happen and then we do management on the 4th pregnancy? No. So from the time of the first abortion, okay, from the time of the second, if we do not identify earlier, if we do not think of the recurrent abortion from the beginning. So nowadays, we will not wait for the 3 abortions to say, okay, this is recurrent abortion. So we will investigate and we will try to manage accordingly. So this ends my presentation. So I would like to open the floor for the discussion. If you still have question, yeah. Is there any more question by the time you can also post question or post garda huncha हैन. Okay, recurrent abortion के question रहेछ एउटा हैन. अर्को रहेछ significance in mentioning whether the pregnancy is planned or see this question, significance of mentioning whether the pregnancy is planned or unplanned. Well, yes, there is significance. I will say there is significance. It is because there is a terminology called pre-pregnancy counseling. So most of the pregnancy, if you have been to outpatient or if you have been to know about your family members or they will come to do testing pregnancy. Nowadays, everyone can do urine for pregnancy testing. So you testing usually they do it when the missed period is more than 2 to 3 weeks. And by the time it will almost be 7 weeks pregnancy. I know. By 9 weeks of pregnancy, the organogenesis will be over. Okay. So if there are some risk group who can have folic acid deficiency or some other nutritional deficiency, so if we come to know that earlier, we can prevent some mishaps, maybe mishaps. This abortion may be because of the chromosomal abnormality or folic acid deficiency because of some of the condition that is happening with the folic acid deficiency, so we could have prevented. So if they come 3 months, if we start preparing for the pregnancy at least 3 months earlier, maybe when I say pre-pregnancy counseling, it is not only limited with the folic acid, it is with the preparing the body. If underweight, put on weight. If overweight, just reduce weight. Nutritionally, deficiency, anemia, or some other conditions, so that we could have been planned, okay, and managed. How we get certificate of participation? Please ask Iwa or other you. So I'm going to recurrent abortion ko ma alikati bhanna जाँदैछु है त है. Yes, हैन, recurrent abortion ko लागि I have not gone detail किन भन्दाखेरि चाहिँ because this is going to be one different presentation नै अर्कै हुन्छ. Recurrent abortion is that vast, हैन. So recurrent abortion, see, yeah, just I have mentioned the heading, hormonal disorders, very common, very common. Okay, just I have mentioned about the corpus luteal defect, so there are people with the tendency having corpus luteal insufficiency, so corpus luteum it develops after ovulation, ovulation, like, so normally if pregnancy will not happen, so it will regress by 9th day, 9 दिनमा ovulation भएको 9 दिनमा के हुन्छ त, so corpus atreticum bन्छ, so it will be no more functioning, it will be no more secreting hormone. But yes, pregnancy भयो भने, so peak hormone 9 weeks, but alikiti progesterone it will continue to secrete later on also, even 12, 13, so this defect is going to give, if it is there, so usually you सबैमा हुँदैन, there may be ovulation कति मान्छेहरुको के हुन्छ त भन्दाखेरि ovulation timely हुन सक्दैन because of the thickness. So there are different mechanisms which will prevent the blood supply to the corpus luteum. So if we can prevent that, so we can prevent the recurrent abortion, so maternal infection, different maternal infection, immunologyहरु हुन सक्छ, okay, so infection को कुरा गर्नु पर्दाखेरि I will be giving example of torch infection, which nowadays been mentioned that actually it has very less role for recurrent abortion, but it is not very true, so very common one is rubella, rubella co infection. If more than 10-fold rise in the rubella भयो भने, it is going to damage the brain, so के हुन्छ त भन्दाखेरि demise हुन्छ, so if we can come to know that earlier, so if there is abortion, so you don't wait for the next 2 abortion to do torch test, so torch panel can be sent, so torch panel गर्दाखेरि IgG, IgM you will be seeing, and if recent infection छ भने there will be the IgM, so depending upon that you can treat patient. If IgM, you are going to see the titration, whether this is the recent old infection near old or late old, you can see. Also you can identify the level, okay, titration here is again, so titration depends, if it is more than 10-fold then you can treat. Maternal immunity related, blood group related, ABO incompatibility related, RH incompatibility related, maternal medical disorders diabetes हुन सक्छ, okay, त्यसपछि आएर के त भन्दाखेरि renal disease हुन सक्छ, hypertension हुन सक्छ, okay, And the very common one is the chromosomal abnormality. So now previously it was not done, but nowadays if you are thinking, why don't you do karyotyping if possible, which is good tissue line fresh tissue. If not, maternal blood can be sent for the karyotyping. Okay. So the other one, last but very commonly happening, is the uterine anomaly. So if uterine anomaly, especially the Mullerian anomaly, okay. So Mullerian anomaly भनेको चाहिँ कस्तो त भन्दाखेरि maybe septate uterus, maybe bicornuate uterus, unicornuate uterus, So if it is there, arcuate uterus. So these all can give rise to when your contour, uterine uterus भित्रको cavity को जुन contour हुन्छ नि, if the contour is not maintained, suppose हुनुपर्ने oval shape, but it is going to be heart shape, like अर्को यस्तो shape भयो भने के हुन्छ त भन्दाखेरि, if oval shape भयो भने, so you know about the Braxton Hicks contraction, no? So it is going to get generated from the cornua and then distributed all over the uterus. So त्यसले गर्दा के हुन्छ त भन्दाखेरि oval or round shape मा चाहिँ equal pressure maintain हुन्छ, or heart shape अथवा चाहिँ shape different हुने बित्तिकै के हुन्छ त somewhere the pressure, the uterine pressure will be dominant and it will not be equally distributed. That is going to give rise to the abortion very frequently. So this is how the recurrent abortion is going to have made you clear bio. So I'm going to take further any questions. How I question chat box. Okay, there's no more question. So thank you everyone. It was nice time.
Thank you, ma'am, for very detailed and clear explanation about topic. It was very informative session. And thank you, Iwa Didi, for beautiful presentation. Now I would like to present a small token of love which you have prepared for you. I request Achal to kindly share it for Dr. Anjana ma'am.
Thank you so much.
I request ma'am to say a few words regarding today's program and degree Medicos as well.
From the time of this beginning of the pandemic, so we were thinking about having a group discussion. So we have not thought of all medical college, but we were planning. Our Vice Chancellor, Sir Professor Dr. Ramkanta Makaju, so he initiated with an idea that with this time we should take advantage of internet. We should take advantage of gathering all the students from our all affiliated medical colleges, and we should start classes. And I did some of the classes, not for all, but we have our medical college, Devdaha Medical College, where they asked me to have some lecture. So I did it it was a year back. So it was nice experience for me and I was really excited. Okay, so we have to start this. So we have again made a pool of the faculties from our Dean Office. So I have given the list of the pool of the faculties and they have started taking classes for the 7th semester and 9th semester last year. Okay, last year. So this was again, there was break bio. It's because exam bio. So this is the time we are going to start again. And another idea was also to have international pool of the faculties so that all the students will be benefited. So this was what I was trying, but again from the students, our students, okay. So they invited me for this. So I have to say that you are a step ahead of us. So I'm very happy to be a part of this Grey Medicos. and I'm very happy that you have already initiated this. See, I'm the person which I mean, you share the knowledge, you will add your knowledge. So this is, no, so you have not limited to keep this to yourself. So you have initiated this so that the quality of our medical students from the who are graduating from Nepal, so it is going to be quality will is going to be improved. So thank you very much for the initiation, and I thank all the participants for the participation. Thank you, Ayusha.
Thank you so much, ma'am, for those inspiring words. It means a lot for us. Also, I request Aja to kindly share a token of love to Iwa Didi. Iwa Didi, we would also like to hear from you as well.
Yeah, it was a great learning experience for me as well. Thank you so much, ma'am, for such deep insight on the topic. Also, I got to research about the topic while preparing for the case. So it was a great learning experience, and thank you to the Grey Medicos team for bringing such a lovely platform where we all medical students can learn. And also present on various topics. I have been following you since it started. I have been attending every seminars or webinars you all have conducted, and it has helped me clinically. So thank you so much, and I wish you all the luck in the further days. And so yeah, that's all. It was a lovely experience, and thank you everyone.
Thank you so much, Dee. Now I request Posan Sapkota from KUSMS to propose a vote of thanks.
Thank you everyone for participating in the session. I would like to thank you, especially our QSMS academic coordinator, Dr. Anjana Dangol, Associate Professor, for giving us a wonderful session on abortion. We are blessed to have you, ma'am, and hoping for more session with you. Also, we'll be having more session like this, and we believe we'll have more support from our QSMS faculty and all over the medical college. Thank you.
Thank you, Posan. Once again, I thank Posan for coordinating such excellent program on behalf of KUSMS. Now we are at the end of program. I would like to congratulate and thank all the working team member of Grey Medicos for their constant help and support and pulling of today's program also successfully. And thank you all the participants for your active participation. We have been regularly uploading our session on our official YouTube channel as well. Whoever was unable to attend previous session, you can watch it over there. Thank you everyone. Once again, I thank Dr. Anjana ma'am and Iwa Didi for very fruitful and insightful discussion. Thank you everyone. I request host to end the meeting.